My dad works in B2B marketing. He came by my school for career day and said he was a big ROAS man. Then he told everyone how much he loved calculating his return on ad spend. My friends still laugh at me to this day.
Not everyone gets B2B, but with LinkedIn, you'll be able to reach people who do. Get a $100 credit on your next ad campaign. Go to linkedin.com/results to claim your credit. That's linkedin.com/results. Terms and conditions apply. LinkedIn, the place to be, to be.
Well, hi there. I'm Nurse Mo, and this is the Straight A Nursing Podcast, and I'm so glad you're here. This is where I teach concepts and share tips on how to thrive in nursing school and beyond that at the bedside. Today, we're diving into a fundamentals topic that is of very high interest to both students and practicing nurses because it addresses a very big infection control issue. Now, before we hop into that, let's take a minute for our listener shout out. And this shout out goes out to Sabrina, who says this: "Thanks for everything, Nurse Mo. Just dropping by to say thank you. This podcast has been absolutely invaluable to me during the last 2 years of nursing school. You were my commute buddy and study buddy and got me through so much test prep when I just couldn't focus on reading anymore. As someone with ADHD and trouble focusing, having the option to listen to content I could trust made a world of difference. I'm actually getting a little misty as I write this because as of yesterday, I passed the NCLEX and am officially an RN, and you were a huge part of my journey." Sabrina, wow, thank you so much for telling me how much the podcast has helped you. I'm getting a little misty too. I love just being a part of so many students' journeys to become nurses. And I'm just thrilled that you passed your NCLEX and you're a practicing RN now. Way to go. Alrighty, are you ready to dive into this week's topic? We're talking about UTI prevention, specifically catheter-associated UTI prevention. So this is often referred to as a CAUTI, catheter-associated urinary tract infection, CAUTI. And these are infections associated with the use of an indwelling urinary catheter. And according to the Infectious Disease Society of America, there are some specific criteria in order for an infection to be identified as a CAUTI. And this includes the presence of an indwelling catheter for more than 2 days, one sign or symptom of infection, at least one sign or symptom of infection, and a positive urine culture. So if the patient has, suspected urinary tract infection, but they haven't had the catheter in for 2 days, then that urinary tract infection was likely already brewing before they got the catheter, so it's not going to be deemed a CAUTI. Does that make sense? And the reason that we really want to be specific about what is deemed a CAUTI is because hospitals are working so hard at preventing these. CAUTI is actually one of the most commonly reported hospital-acquired conditions. And they have a huge impact on length of stay, on healthcare costs, and on patient mortality. So looking at length of stay, according to the Agency for Healthcare Research and Quality, a CAUTI increases length of stay by 2 to 4 days. Now, obviously, if there's some kind of significant complication, and we'll talk about those in a moment, that can be drastically extended. And then there's cost. On average, the cost of treating a CAUTI can range from $900 all the way up to $14,000 per case. And this is estimated to be about $340 to $450 million per year in the United States. So it is huge. And get this, since most cases of CAUTI are preventable, Medicare and Medicaid are not reimbursing hospitals for these costs. So you better believe your hospital where you're doing clinicals, or if you're a nurse, your hospital where you work, or a long-term care facility where you work, they are real interested in reducing CAUTI. And then mortality. So a CAUTI can definitely have complications, can definitely lead to patient mortality in critically ill patients specifically. And the mortality rate for CAUTI amongst this critically ill patient population is 30%. It's actually estimated that more than 13 patients die each year due to CAUTI-related complications. So very, very serious, very, very preventable. So we want to do what we can to prevent them. And just a quick note that UTIs obviously can occur without the use of a urinary catheter. However, in the hospital setting, approximately about 65% of all UTIs that develop in the hospital setting are associated with the use of a urinary catheter. And since there's such a focus on CAUTI prevention, that is what I'm talking about today. Urinary tract infections associated with an indwelling catheter. So now let's talk a little bit about how CAUTIs occur. I'm going to mention some information I found that suggests why they occur. We'll dive into the complications, patients who are at risk for a CAUTI, and then we'll dive into kind of a step-by-step approach for CAUTI prevention. So let's first look at how they occur. So and if you remember nothing else, remember this, the most significant determinant in the development of a catheter-associated UTI is duration of catheterization. So how long that indwelling catheter is in place. And the risk increases by 3 to 7% for each day that indwelling catheter remains in place. Catheter insertion itself causes histological and immunological changes in the bladder, which leads to an inflammatory response and edema. And then additionally, the presence of a catheter really is irritating to the epithelium of the urinary tract, leading to ongoing inflammation while also disrupting normal urination and weakening of the urinary tract's natural defense mechanism. So what do you think happens? This allows microbes to create a biofilm on the catheter, and it just creates a perfect environment for the breeding of bacteria. And with this biofilm, pathogens, microbes, whatever you want to call them, can easily find their way into the body. Further, catheters cause continual mechanical damage to the urinary tract, which leads to the accumulation of fibrinogen in the bladder. And the fibrinogen then spreads to the catheter itself and provides a ripe environment for some very specific pathogens such as Staphylococcus aureus and Candida albicans. So few different reasons why or how CAUTIs occur. Now, the most common pathogen involved in CAUTI is E. coli. So in summary, the presence of a catheter and the associated inflammation modify the urinary tract and bladder. It disrupts the urinary tract's natural defense mechanisms and creates opportunities for microbial colonization and infection. One key thing to note is that there are catheters out there that are made with antimicrobial coating to help delay the creation of that biofilm. And honestly, the jury is still kind of out. I think more research needs to be done in this area because even with these specialized catheters, CAUTI rates remain high. They remain higher than we want them to be. And again, really increase patient healthcare costs, patient length of stay, and patient mortality. So you might be wondering, well, why does this occur? We know how they occur. Why are they happening? So a root cause analysis conducted in 2019 that I found as I was doing my research showed that the most common factors associated with the development of a CAUTI are going to be the patient's comorbidities. So depending on what their comorbidities are, some patients are going to be more likely to get infection. And with that one, there's not that much we can do about it. The patient's comorbidities are what they are, but some of these other ones are definitely going to be modifiable. So one of them is simply substandard catheter care. And we'll talk a little bit later about how to do excellent catheter care. The presence of fecal incontinence increases the risk, which totally makes sense. And again, the duration of the catheter use, how long it is left in place. So earlier I mentioned that CAUTI can cause complications. It can really increase cost, length of stay, all of that. So unfortunately, a catheter-associated urinary tract infection is more than just a UTI. It definitely can cause some serious and even deadly complications. So these include, for starters, sepsis and septic shock. I took care of so many patients in the ICU who had sepsis, and the source was a catheter-associated urinary tract infection. And sepsis, if you're not familiar, is an overwhelming inflammatory response in the body that can lead to hemodynamic instability and death. Another complication is pyelonephritis, which is inflammation of the kidney resulting from a bacterial infection in the kidney. The patient could also get bacteremia, which is a bloodstream infection due to the presence of bacteria. Another very serious one is endocarditis, which is inflammation of the lining of the heart chambers and the heart valves. It is very difficult to treat. Patients often have to take IV antibiotics for a very lengthy period of time. Another complication is septic arthritis, which is an infection in the synovial fluid. Meningitis is another complication of CAUTI, which is inflammation of the tissues that surround the brain and the spinal cord. The patient could also get vertebral osteomyelitis, which is infection affecting the bones of the vertebrae. And then there's urolithiasis, which is kidney stones that are basically, they were in the renal pelvis and now they've moved into the ureter's bladder and or urethra. Very, very painful. And another thing to consider is antibiotic resistance. When we look at some of the common pathogens that are responsible for catheter-associated UTIs, quite a few of them are resistant to antibiotics, which makes treatment very, very challenging. All right, let's now look at who is most at risk for getting or developing a catheter-associated UTI. So first off, I'm going to say incontinent patients. So let's say you've got a patient in the hospital with an indwelling catheter and they have incontinence, fecal incontinence. We're taking care of the urinary issue with catheter, but they have fecal incontinence. And as you can imagine, the pathogens from the stool can easily find their way onto that catheter. And if there's a biofilm there, hallelujah, they've got a really easy way to colonize, keep moving, and just travel right up into the body. And then also maybe your patient just has a long-term indwelling catheter. Maybe they're caring for it themselves and they're not doing a great job. That's also going to really put them at risk for a CAUTI. Next, we have immobile patients. You're looking at patients with maybe very serious injury who cannot get out of bed, patients who are critically ill, patients on ventilators, that type of thing, patients with paraplegia. So studies show a very, very direct correlation between immobilization and CAUTI. This is believed to be due to decreased urine flow from the renal pelvis into the bladder because we're basically, when you stand up, you're helping. Gravity helps. Gravity's great, right? It's going to help things flow from the renal pelvis into the bladder. But when your patient is lying in bed all day, all night, they're not getting that flow down into the bladder. And the urine can't drain out of the bladder, even with a catheter, if it's not in the bladder, right? All right, so next patient that would be at risk for a CAUTI would be patients with diabetes. So individuals with diabetes are at higher risk for CAUTI for a variety of reasons. And one of those is simply because diabetes causes neuropathy, which can lead to inadequate bladder emptying, which then creates an environment ripe for bacterial growth. Second, individuals with diabetes, especially poorly controlled diabetes, have higher blood glucose levels in the urine, which inhibits leukocyte performance. And what do you think bacteria love? They love sugar. So this creates an environment favorable to bacterial growth. And then simply using a latex catheter. Latex catheters have been shown to have a higher risk for CAUTI. And also gender. Females have a shorter urethra, so they're going to be at higher risk for CAUTI than male patients simply because that pathway from external to internal is much shorter. And then age is a factor. Individuals over age 60 are thought to be at higher risk for CAUTI, and this is possibly due to the presence of comorbidities. Patients with neurological conditions are going to be at higher risk. CAUTI rates have been shown to be higher in patients with stroke, cerebrovascular injury, and paraplegia. And then caregiver factors absolutely come into play. If we're in a caregiver situation where there is poor catheter maintenance, we're looking at a UTI happening. And then length of catheterization. Again, if you remember nothing else, remember this. The biggest determinant of a CAUTI infection is how long that catheter is in place. Next, we'll talk about what you're really aiming to learn here is how do we prevent catheter-associated UTI. Let's take a quick break and then we'll come back for that. What's not to love about fall? The days are cooler, the cozy nights at home are longer, everything smells like pumpkin spice, and it's when I transition from lighter white wines into the reds. And my favorite reds are the Pinot Noir selections I've been getting from First Leaf, which is a personalized wine club that sends me hand-picked selections each month. In my most recent order, I received 3 bottles of Pinot Noir, one from California, one from Chile, and one from France. And I have to say, I couldn't even pick a favorite. They were all so good. It's like First Leaf knows my wine tastes even better than I do. I'm telling you, popping open a bottle of Pinot Noir, cozying up with my husband on the sofa, and watching a movie is my idea of a perfect evening at home. So to get started with First Leaf, all I had to do was fill out a quick questionnaire about my wine preferences. And then as I get shipments, I rate and review my bottles so they get to know my wine tastes even better, which means each shipment gets better and better. I'm telling you, it's like having a wine expert on hand each and every time I shop. So get cozy and pop open that perfect bottle of wine from First Leaf. Go to tryfirstleaf.com/nursemo to sign up, and you'll get your first 6 hand-picked bottles for just $44.95. That's tryfirstleaf.com/nursemo. tryfirstleaf.com/nursemo. So we are talking now about how to prevent a catheter-associated UTI. And again, because most cases of CAUTI are preventable, really dedicated efforts have been underway since about 2009 to reduce infection and are now very widely adopted by healthcare systems throughout the United States. So in the clinical setting, you'll likely see CAUTI prevention tactics referred to as a bundle. And if the concept of bundles is new to you, this was a concept that was developed by the Institute for Healthcare Improvement. And they developed this concept of bundles to help healthcare practitioners provide more effective care for their patients. So a bundle is a set of interventions that when completed in their entirety, when we do all the components of the bundle, then we drastically help reduce complications. So, to help with this, the American Nurses Association has developed a CAUTI prevention tool. And this tool is created by them to help guide evidence-based practice to reduce catheter-associated urinary tract infections. So let's dive into it and we'll go through it step by step. So the very first step is to determine, hey, does this patient actually meet criteria for an indwelling urinary catheter? And the Centers for Disease Control and Prevention have come up with a specific list of criteria for patients who basically meet criteria, qualify for an indwelling urinary catheter. And that's going to be a patient with acute urinary retention or some kind of outflow obstruction, or a patient who really does need very strict I&O monitoring. And this is going to be in your critically ill patient. It could also be a patient with a specific surgical procedure, such as colorectal surgery, and then those involving the genitourinary tract. Lots of patients after any kind of genitourinary tract surgery will have a catheter. Also, if the patient has a sacral or perineal wound and they are also incontinent, that wound's not going to heal very well. It actually could get a lot worse. So a catheter would be indicated for that patient. And then you might have patients who are unable to mobilize or even get on a bedpan because they have a specific type of injury, such as a pelvic fracture or an unstable spinal injury, for example. And then another criteria is to provide comfort at end of life. So step one, does this patient meet criteria for an indwelling urinary catheter? Notice straight up incontinence is not a criteria for an indwelling urinary catheter. So if the patient does not meet criteria, then it's really up to the nurse, maybe working with the interdisciplinary team as needed, to develop a toileting plan and consider the use of alternatives such as external catheters and urinals or timed toileting and things like that. So that's step one. Does this patient meet criteria for a catheter? Now, let's say they meet criteria, so we're moving on to step two. Now is when we're going to go through the American Nurses Association's catheter insertion checklist. And this is to ensure proper, perfect, absolutely stellar technique. So this involves first and foremost selecting the smallest size catheter appropriate for the patient. Remember, I talked earlier about how irritating and damaging the catheter itself is to the urinary tract. So a great big catheter going to cause more damage. A smaller one that fits perfectly is going to cause less damage. And in most cases, a 14 French catheter is adequate in adults. We also want to make sure we have the right assistance. This could be, and it often is, utilizing another nurse to help with the catheter insertion, especially with female patients. It just really helps to have another set of hands to make sure everything can be easily visualized. Maybe even shining a flashlight to visualize the urethral meatus, things like that. So you want to get another nurse in there. It's a team project. Nursing is a team project, I always say. Or it could be utilizing a mechanical aid, such as a lift device. You just want to make sure you've got the patient in the prime position to ensure really clear visualization of the perineal area and the ability to perform proper insertion technique. So those are the first two things you're going to do. Get the right sized catheter and get a friend or get some kind of assistive device. And then we're going to make sure our hands are nice and clean by performing hand hygiene. And then we're going to do cleaning of the perineal area. And we're going to do that. And then we're going to perform hand hygiene again. And then, as you learned in nursing school as a student, we're going to insert that catheter maintaining very strict aseptic or sterile technique from beginning to end of the catheter insertion process. Now, even though you might still see this in some places or at some schools, it is no longer evidence-based to pre-inflate the catheter balloon. So don't be doing that, okay? If somebody is doing that at your school or doing that at the place where you're precepting or working, then it would be really in the patient's best interest to provide some education about how that is no longer evidence-based practice. All right, once we're doing our sterile technique or inserting our catheter, we're going to make sure it is inserted to the appropriate length. So in a female patient, this is generally about an inch beyond the point where you see urine flow. And then in male patients, you're just going to go all the way to that Y connection. Just go for it. Go all the way to that Y connection. Now, lubrication of the catheter is a really crucial step because it reduces patient discomfort and it reduces urethral irritation. More irritation means more risk for infection. But do note that if you glob the lubricant onto the tip of the catheter, it can clog the little openings where the urine is supposed to flow through. And I've seen this a few times as a nurse. Lots of lubrication on the catheter, get it in the urethra, but no urine flow. Like, where the heck is the urine? I'm sure I'm in the right place. I'm sure of it. And then as we came to discover, that catheter tip was just basically clogged with a bunch of lubricant. So you want to make sure you don't have too much on the very tip and you have some on the length of the catheter as well. And then here's the very important thing. You're not going to inflate that balloon until you have urine flow confirmed. So you're going to get the catheter into that appropriate length. We have urine flow. We're going to go a little farther in our female patient. We're going to go all the way to the Y connection in our male patient. And then we're going to inflate our balloon. And we're going to make sure that we only inflate the balloon to the correct volume. And it will be labeled if it's a 10 mil balloon or a 5 mil balloon. And then the little kit, the Foley catheter insertion kit is going to have that pre-filled syringe. So don't be going and grabbing a different syringe and putting 10 mils in a 5 mil balloon. Okay, that's not going to be good. It's probably going to cause the balloon to not work. All right, so that was step 2. We are inserting our catheter perfectly. Now for step 3, once the catheter has been inserted, we're going to do 3 key things to help prevent CAUTI. One is we're going to use a catheter securement device. And this prevents the catheter from moving around a whole bunch and really irritating the urethra. The ones we use the most in my hospital are, I think it's called a stat lock, and it's adhesive. So it has a pretty strong adhesive. It sticks right to the thigh, and then everything stays in place. You may also see a type that is more like a stretchy band that just wraps around the thigh. Honestly, I'm not a huge fan of those because they do move around more. So if your facility has the option of the sticky ones, use the sticky one. You also want to ensure the drainage bag is below the level of the bladder and also not resting on the floor. Now, most, if not all, hospital beds are going to have a little spot towards the foot of the bed where you can hang catheter drainage bags. So hang it from there. And then the third thing you're going to do after the catheter has been inserted is maintain catheter patency by ensuring there are no obstructions or kinks in that catheter. Alrighty, so that was step 3. Step 4 is a daily practice. Actually, it's probably done every shift in some cases, but at the very least, it's done every day. And you reassess daily to ensure the patient still meets criteria for an indwelling catheter. Now, in many facilities, there are protocols in place. You follow like this algorithm, and this algorithm and protocol allow you as the nurse to determine if the catheter can be removed. If not, if you have to wait for an order from the physician, and that happens a lot too, once an order is received from the physician to remove that catheter, please remove it promptly. Don't dilly-dally and wait half the day to do it. Get it out as soon as possible because that risk for infection goes up the longer that catheter stays in place. And then step 5, and our final step, but it's a big one, is to maintain the catheter system pristinely throughout the duration of use. So what does this involve? Okay, first of all, and some of this is going to be a little bit of a repeat, but we're going to ensure that that catheter securement device remains in use. Again, let's say you've got the type where it just wraps around the leg. and your patient has gotten up to walk around. When they get back in bed, do you think that that catheter securement device is in optimal position? Probably not. They've been moving around. So you just want to be checking it and make sure that it remains in use and it remains appropriately positioned for that patient. Again, the sticky ones, way more stable. So that's one, ensuring that our catheter securement device remains in use. Two is always making sure that drainage bag remains below the level of the bladder at all times. So here's something that I would see a lot in the ICU. Let's say we're moving a patient from the bed onto the CT scanner table, for example. Somebody will just grab the catheter bag and just plop it on top of the patient's lap, basically. What do you think that does to the flow of urine that's been sitting there in that bag? Where do you think that urine now goes? It's going to head towards the bladder. So this is a really easy way to get a CAUTI. So what I suggest is either holding onto the drainage bag throughout the transfer, keeping it below the level of the bladder. If that's not possible, maybe you have to also help with the transfer. You don't have an extra set of hands. You can clamp it prior to placing it where you need to for a safe transfer. Just be sure to unclamp it once you have it back in position below the level of the bladder. Okay, you would never, ever, ever want to leave a Foley catheter clamped because that is causing a urine outflow obstruction and can cause a lot of problems for your patient. All right, another thing we're going to do is we're going to make sure we don't let the bag get too full. We're going to empty it regularly with a clean collection device specific to that patient. I'm not saying you have to get a new collection device every time, but after you dump the urine out of the collection device, rinse it out, okay? And you don't want to share collection devices between patients. While you're emptying, do not let the drainage spout touch the collection device or the edges of the collection device. And in some facilities, it's actually protocol to wipe the drainage spout with an alcohol swab after emptying and before clamping everything back together. You also want to make it a habit to always just be kind of eyeballing the bag to make sure it is not touching the floor. This can very easily happen when placing a patient, let's say, into reverse Trendelenburg, for example, or if for some reason you need to lower the bed all the way to its lowest position. Maybe the patient has a seizure disorder and you need to have the bed very, very low for seizure precautions. You want to make sure that that bag is not touching the floor. And then you're also going to maintain catheter patency by ensuring no kinks in the tubing, no obstructions in the tubing. And here's a great example. Let's say your patient had renal surgery or bladder surgery, and they are going to be having some blood in the urine. They could even have blood clots in the urine. So you really want to keep an eye out for these so that you can flush them through before they cause an outflow obstruction and urinary retention. So to flush a urinary catheter, you're going to get some sterile normal saline, and 10 mils is not going to be enough. I like to get a 60 ml syringe, so the big syringe, and hook up a bag of normal saline to IV tubing. I'm not going to hook it up to the patient. I'm just going to hook up the bag to some IV tubing, and then I'm going to take my big syringe, my big 60 ml syringe, lure lock that onto one of the ports on the IV tubing and pull like 30 mils out of that normal saline bag. Okay. You could just grab 3 flushes for 30 mils, but I find it's more effective to have one continuous good flush of 30 mils, and you can only do that with that big syringe. So then, obviously, of course, before you attach that syringe to the IV tubing, you're cleaning that port really, 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 really well. And then what you're going to do is, you've got your hands clean, you've got some gloves on, you're going to get an alcohol swab, a fresh alcohol swab, and vigorously scrub that little port, that little infusion port on the Foley catheter. It's not the same one that you use to inflate the balloon. This is a port so that you can flush the catheter. And you also want to clamp the catheter so the saline flush goes the direction you want it to. So if your clot is downstream, clamp above that port. Okay, so you could probably just like kink the catheter tubing a little bit And that way, when you push the saline, it's going to go away from the patient towards that clot and hopefully clear it. A lot of times, though, the clot is inside the smaller part of the catheter, the part that you can't see. So let's say your patient has had a drop in urine output. Their urine's been kind of clotty, kind of bloody, and you think, oh, I bet there's a blood clot in there. Well, if you don't do anything about that, you're definitely going to have an obstruction. So in that case, you're clamping below the point of that infusion port and flushing toward the patient. You're flushing into the bladder and clearing out any clots that might be in that catheter. So that's how you would flush a catheter. And then you always want to remember to document that so that you incorporate that volume in your I's and O's. Another thing to do to maintain your catheter system pristinely is to always maintain a closed drainage system and only open that drainage spout for periodic collection bag drainage. And you just want to keep your connections nice and secure in your Foley catheter system as well. And then if that catheter tubing becomes dislodged or the tubing gets cracked somehow, you're replacing the whole setup. And then another thing, very, very important, is to perform perineal hygiene, or what we call catheter care, per facility protocol. In most cases, this is going to be once per shift at least. And then when the patient has any episodes of fecal incontinence, anytime you're going in to do a cleanup of the patient, you're also doing catheter care and keeping that perineal area absolutely spotless, okay? You can do all these things, right? So that is your deep dive into the American Nurses Association CAUTI prevention tool. If your hospital is doing things slightly differently, it's going to align more or less along with this. And I will put a link in the episode notes so you can go and grab that tool. It's a PDF. You can print it out. It's very, very helpful. So in closing, I'm going to leave you with a little acronym that I found to help you remember the key components of CAUTI prevention. And it's CAUTI. So C stands for catheter removal. Get that catheter out as soon as you possibly can. A stands for aseptic insertion. You want to make sure you have the proper training and skill for catheter insertion. And if you're not sure, ask a friend for help. Or if you're not sure that you can do it aseptically, maybe because of an issue with the patient, or maybe they can't mobilize their hips very well, you're going to need some help. Get a buddy in there to help. U is for use regular assessments. Remember, you're going to reassess your patient's need for a catheter daily. You're going to be looking at the site, making sure it's nice and clean, all of that. And then T stands for training for catheter care. So make sure you know how to do adequate catheter care. And if your patient is going home with the catheter, make sure you're teaching family and the patient how to care for their catheter. And then I stands for incontinence care planning. You want to always be considering alternatives to catheters with your incontinent patients. Things like external catheters like the PureWick and timed toileting can be really great and effective options. So there you have it, your quick guide to catheter-associated UTI prevention. So if you like learning from me, then I would love to have you check out all the many resources that I have available for nursing students. You can go to the Straight A Nursing Student website. And actually, it's not just for students. Working nurses, practicing RNs, and practicing LPNs or LVNs use my resources all the time as well, because I always say this, as nurses, we're constantly students, right? We're constantly learning. But you can go to the straightanursingstudent.com website, see all kinds of things there. And then if you are a student and you feel like you want a little extra help with school, want concepts explained to you very simply in an easy to understand way, then I invite you to check out the programs that I create for nursing students. And you can actually get all of them in one bundle at a discounted price. So you can go to straightanursingstudent.com /bundle to check that out. That bundle includes Crucial Concepts Bootcamp, which is my nursing school prep course. It includes Med Surg Solution, where I tackle about 60 common disease conditions in a very straightforward, easy to understand, easy to follow format. It includes Fast Pharmacology, which is an audio-based program where I teach pharm concepts in 5 minutes or less. And it also includes Study Sesh, which is another audio-based program. It's another private podcast where I do a lot of pod quizzing where I ask questions and give you time to answer. It's kind of like flashcards for your ears. I do some case studies, some Power Hour deep dives, and some drills to help really drill in those few things that you do actually need to memorize for nursing school, like cranial nerves and stuff like that. So if that sounds great to you, then I'd love for you to check out the bundle. Again, straightanursingstudent.com/bundle. And I look forward to seeing you back here next week. I think I know what I'm talking about, but I don't want to say it just in case I change my mind. Regardless, it'll be great. And I'm super excited to spend some time with you next week. Bye for now. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.
At a time when change is constant and we are pulled in far too many directions, we need a way to stay present to life and to increase our ability to remain calm, think clearly, and maintain our well-being. Many studies indicate mindfulness improves our mental, emotional, and physical health. On A Mindful Moment with Teresa McKee, you can learn how to practice mindfulness and enjoy its many benefits. Tune in for guided meditations and to hear tips and advice from some of the most respected experts in the fields of mental health and mindfulness. The world truly can be a better place. It all starts with a mindful moment.